Welcome to Health IQ. I'm Dr. Alan Siegel. Tonight I have Dr. Seth Shifrin, is triple board certified in internal medicine, pediatrics, and sports medicine. Welcome, Dr. Seth. How are you?
Very well, thank you.
So tell us about your specialty of sports medicine. It's kind of unusual. How does that differ from being an orthopedic surgeon?
Okay, great. That's a great question. What I do is all non-operative interventions. So I'm primarily concerned with diagnosis and non-surgical management of a number of different conditions that affect the musculoskeletal system, both acute injuries as well as overuse type of syndromes and even osteoarthritis throughout the body. What differs me from an orthopedist is I'm not a surgeon, so orthopedic surgeons are surgeons. It does get confusing because there also are orthopedic sports medicine doctors, and that's not what I am. I'm a primary care sports medicine doctor.
So primary care, meaning you would see a lot of injuries initially. If someone had an initial injury or a more chronic condition, they may come see you first, almost as a gatekeeper before seeing an orthopedic per se.
That's exactly right. Yeah, if you get to me, hopefully you don't end up going to the orthopedic surgeon. But I work very closely with my orthopedic surgery colleagues so that if a surgery is indicated or necessary, then of course I would be able to transfer you to the surgeon who might specialize in that particular problem. So a gatekeeper is a very good analogy for that.
And with your background also in pediatrics and in internal medicine, you probably see different, youth clientele. But I assume you see all different types of people, age-wise.
Absolutely. I mean, the other day I saw a 14-month-old baby and then saw an 89-year-old woman back to back. So, I mean, we run the gamut in terms of age ranges. And like you said, the other main difference between myself and an orthopedist is that in my training, I started out in primary care. So I did an internal medicine residency and a pediatrics residency. And then I went on and did a fellowship in sports medicine. So I come with a very generalist background, and I think that helps me in functioning, as you said, as a gatekeeper.
So you probably see a lot of diversity in the conditions they treat, because some orthopedics are very, very specific these days. They
Right.
only work on the shoulder, only work on the knee, only work on the foot and ankle. Being a primary care generalist in sports medicine, you're probably seeing conditions of all areas of the body.
Absolutely.
Right?
I go from head to toe. I see concussions down to toe problems, and everything in between.
So it's a diverse group of clientele.
Absolutely. Yeah.
You did mention concussions. That's actually a pretty good hot topic right now. What's going on in the industry and with youth athletics, parents' concerns about these concussions and the repetition of these concussions.
Yeah.
How are you advising your patients and your patients, maybe parents, if it's a youth athletic injury, how are you advising them in terms of like continuation of sports? Do they have to go through a clearing process?
Right, so that's a great question, yeah. I do have a very specific protocol for returning patients to sport, and I tend to be more conservative, of course, the younger the age group. So concussions have become such a hot topic, such a common problem for athletes. Oftentimes, if it's a complex concussion, if it's a concussion that's taking a long time to get better, or there are other side effects or symptoms that we're seeing,
persistent, right?
Then I will manage those in conjunction with the neurologist. I won't do that solely by myself, but the bottom line is if a patient has a concussion, especially a younger patient, I don't think they should return to play in that contest or that game at all. And I think usually it takes about a week to get back to full sports. And like I said, there's a very specific progression that I like to use, from starting with just light jogging on their own to building up to more sports-specific activities, and finally getting back to practice and then a game. But they have to pass each level to get on to the next level.
So you have a conservative approach to getting back to whatever they're doing. Now, is the concern of repeat of the incidents once you've had a concussion, is that something that parents should be aware of? Are they more likely, or is the statistics show that they could have a higher incidence once they've had their first concussion, have a repeat, and then are the effects cumulative?
Absolutely. Absolutely. So, it's one of those things where we don't know how many concussions are too many, but we don't know it until after it happens, unfortunately. So, you have these kids, they've had one, they've had two, after an athlete has had 3 or more concussions, I will usually sit down with the athlete, with the family, and talk to them about seriously reconsidering the sport or activity that they're in.
Right.
And that may
That
sound
must be a difficult
kind of
conversation. Yeah.
It's very difficult.
Yeah.
I'm of the mind that I will never dictate. I'm there to inform the patient. I'm there to inform the family, give them the facts, like you said. Yeah. One of the things that really worries me is if someone has the first concussion and it was kind of a hard blow, second concussion, not as hard of a blow, and then the third concussion, even softer blow. So then what you're seeing is a progression where, it takes less and less to cause a concussion, and then they're lasting longer and longer. Those are the kinds of things that worry me. But in the end, I'm going to make an individual decision, and really it's going to be the athlete and the family that makes the decision. But
work with them.
I'm going to work with them. Yeah.
Yeah, I feel the concussion is an interesting topic. One we could probably do a whole show on, but we'll move on from that topic for a minute. In terms of other types of injuries, repetitive stress injuries that you probably see, your standard tennis elbows, or your maybe your knee patellar tendonitis for runners, or other types of Achilles tendonitis. Yes. Those are common injuries. They're very frequent. What do you typically treat? How would you treat those types of injuries?
Right. So, with repetitive stress injuries, which is the majority of what I see, those are much more common than your acute.
Why do you think that is? That's another good question. Why do you think there's so many repetitive injuries? I mean, people keep doing the same thing over and over and wrong, or they weren't prepared in their sport or in their body to do those activities.
Right. I think there's a number of factors that come into play there. I think sometimes it's a sports specialization really early on, so we're seeing in kids, but we see them, we run the gamut, in older patients, who are running, and once again, all they do is run, they don't cross-train, they're not doing any kind of conditioning work, and then they're just exceeding the threshold which their body can stand. And that goes as well for, your secretary who's sitting in front of the computer for hours a day,
just typing away, doing
typing away. It's all this repetitive activity that we do, and without a lot of variety. So I think that's it. Right. There's posture issues, there's issues with body control. Right. All of those things play into why we see so many overuse injuries. But it's funny,
And do you think they're increasing? Do you think they're actually getting higher than when we maybe were in our youth and doing our athletics back in the day?
So I agree with that. I think a lot of that, like I said, is due to sports specialization, that you see more and more the 11-year-old who just plays baseball year-round.
And just pitches potentially.
Exactly.
Just wants to pitch, and then medial elbow problems.
Exactly, and the jobs, the job forces training, computers have revolutionized the job force, but, we've got people who are on computers 8, 10, 12 hours a day, and the workstations aren't very good, so, like I said, I see athletes, I see non-athletes, so I run the gamut, and you'd ask.
What's interesting is that those conditions are similar, but they just happen from different mechanisms.
Different causes,
different
exactly,
causes,
yeah. And the treatment for that is really, number one, correct the body mechanics, or correct the issue, right? So if it's an athlete that's just running, try to convince them of the benefit of doing some cross training. Have them do a little weight training or resistance training. I don't like to say weight training because that implies just weights.
Right.
But as you know, so much can be gained from just body weight resistance exercises. It doesn't have to be weight.
What they kind of consider functional exercise.
Functional training. That's where it's at. You know, and that's what would reduce these repetitive stress injuries. But it's hard to get that, and it's hard to convince people to kind of do their homework for their sport rather than.
I know both of us having young children. I tell my patients and my friends, I tell my kids to do everything right now. I don't feel that they have to pick or do one thing repetitively over and over again. I don't think it's good for their bodies, and the more they do in a three-dimensional plane and to get their body used to being in a different spatial awareness, the better their bodies will be. And
Right.
and that's just
The better athlete is going to be the one who has good body mechanics and good 3D spatial positioning, like you said. It's not the person who pitches from 9 years old and straight through.
And then when you talk about tendonitis, a very common treatment that people know about is cortisone injections.
Right.
What is your thought on cortisone injection? What has been your experience? Positive, negative, place and a time for everything?
Right. Yeah, I mean, you couldn't have said it better. There's a place and a time for everything. I do a lot of cortisone injections, so I'm certainly not opposed to cortisone. I think the most important thing that anyone can understand when we're doing a cortisone injection is cortisone doesn't fix or cure anything, all right? Cortisone is an anti-inflammatory. It helps decrease inflammation, decrease pain, and what it really should be used for, especially in tendonitis. There's different things. You can use cortisone for tendonitis, you can use it for arthritis, you can use it for a number of different conditions. But when we're using it for tendonitis, which is a common use, I tell my patients, you got to see it as a window, all right? This is giving you 2 months, 3 months where it's not going to hurt as much, where we can really work on the problem. And working on the problem implies doing physical therapy, doing some manual work on it. But sometimes that can be too hard when you're in a lot of pain, right?
I know. I've had patients where they could barely lift up a toothbrush.
Right. How can you work with them? How can you start any therapy, right? So you've got this patient who comes into me who's had tennis elbow, right? And they've had tennis elbow for 6 months. They've been just trying to put it off, just keep playing through it, keep playing through it. You've seen it, you know it. And what happens is, it hurt, like you said, they can't lift their coffee cup up. That's usually when they come in to see me. It's like, well, doc, now I can't lift my coffee cup anymore.
So on a rare occasion, even with like a tennis elbow or tendonitis that's so bad, you may do an MRI and all of a sudden you realize it's a tear, and then it becomes maybe even beyond. Cortisone's not going to help that, or therapy is not going to help that. Sometimes there are surgical interventions for even what we thought was tendonitis.
Right. Although, with tennis elbow, I would say, I get a lot of patients too who come in and say, I want an MRI, I need an MRI. And my response to that was, yes, a complete tear of that tendon, that's a surgical thing, but usually that. That's usually a one-time event.
Right.
What'll often happen is you have a patient that comes in, they've got this kind of chronic 6-month history. They say, I want an MRI, I need an MRI. You're going to get the MRI. It's going to show partial tearing, tendonitis, and that's much more common. And with those kinds of things, there are surgical approaches. So I wouldn't say you never need surgery for that. Right. But much more commonly, and the surgeons that I work with will tell you the same thing, they want to see that all the conservative measures have been tried before they'll even think about surgery. So,
which is an appropriate course of care, or a reasonable course of care.
So my take on it is cortisone shots, physical therapy, or exercises that we teach them to kind of get it going. But like I said, I never want to just do a cortisone shot and leave it at that for tendonitis, because I feel like that's a disservice to the patient.
And how do you feel about over-the-counter and or other types of anti-inflammatory medications in conjunction with these types of therapies, or in between?
I mean, every doctor has their own take on that, and my take on it is just like with the cortisone. Anti-inflammatories don't fix tendonitis. Anti-inflammatories don't cure tendonitis. Right.
Some people might say they actually inhibit the body's ability to heal.
Right. There are theoretical risks. Right. I think when you get back to that, you can do a study and a test tube and show that there's some inhibition of certain healing factors when you put ibuprofen or something in there. But functionally, we've been using ibuprofen for 100 years. I think it's safe to use. So, I don't want to go overboard with that. I kind of feel like
you don't want long-term use of these things for a chronic condition.
I mean, if you do a study and it shows that fracture healing is delayed by ibuprofen by 1 day, I mean, functionally, that doesn't matter to the patient, and it's much more important that the person feels comfortable. So I don't want people avoiding these medicines just because of that. Right. And there's plenty of reasons to avoid medication. You
probably just don't want them taking them.
I don't want to take them long term. We'll try them for a week or so, and then I'll tell people, take them as needed. If it's hurting, take it. But I think also people have to understand, when they hear anti-inflammatory and they say, oh, I've got inflammation because I've got this repetitive strain injury. Anti-inflammatories are very good for treating acute inflammation. They're not so good for treating chronic inflammation. Chronic inflammation and acute inflammation are very different conditions. And so I feel like, once you get into chronic inflammation, they help from pain control standpoint, but they're not really helping with inflammation. And like you said, I mean, there's some reasons theoretically to believe they could delay healing, although I think, once again, I would downplay the functional impact of that.
And you mentioned chronic inflammation. So that really asks the question, what other conditions do you treat? Because you may have an acute tendonitis or even a chronic tendonitis, but then there's arthritis, which is another, it may not be an athletic injury, but over time, a lot of athletes do have arthritis in their knees, in their hips, if they're in martial arts, which I know you're a studier of, and people that do skiing or whatever.
Well, any athlete can end up with arthritis. I mean, the bottom line with arthritis, there's hundreds of different kinds of arthritis, but when we say arthritis, a lot of patients don't understand that. When we're talking about just arthritis, we're really talking about osteoarthritis, which is the most common cause of arthritis.
Which is more degenerative.
Degenerative. It's like the wear on your tires. The bottom line is, if we're lucky enough to live to be old enough, 100% of us will have osteoarthritis. It affects different joints in different ways. You're much more likely to have arthritis in your knees than in your upper extremities, just because we walk on our legs. For a lot of reasons, the knee tends to be one of the most common. Hands actually tend to be pretty commonplace. Ankles not as common, but we see it a lot. Hips is common. Spine is almost universal. So once again,
we'll all have it there eventually.
We're all going to have it, athlete or not. So athletes may have a accelerated course just because of the damage they do to their body. Another thing I like to tell people is there's a difference between exercise and sport, right? Exercise is good for you. Sport incurs risk. So,
that's true.
Being in a sport, you're going to do things to your body that may be above and beyond what would be healthy, whereas exercise means you're doing something in order to improve your health. And so a lot of people come in, they say, I started running because I wanted to be healthy.
CrossFit and all these other things these days, exercise does pose a higher risk these days than maybe it did.
Once again, CrossFit's a sport, right?
Well,
I mean, it's becoming more and more of a sport, and it's almost like fitness as a sport.
But a good example is some women go to CrossFit, have never trained or have never done it before, and they get on these CrossFit machines and devices without any expectation or knowledge, and before you know it, they are injured.
That's the problem. I mean,
not to call out CrossFit as an entity, but I think it's the instructor and the client.
It's the instructor. The bottom line is it's the instructor. The instructor has to be on top of that. You can't have people who've never trained, who don't understand the movements, go in and do something new every day. And that's kind of what CrossFit. And there's a benefit to that. I mean, the concept of CrossFit is a very good one, the constant muscle confusion and stuff like that. So like you said, I'm not here to fault CrossFit, but you take someone especially someone who's not in very good shape to begin with, who's trying to get into good shape, they really need some remedial education before they can, get to what we see on ESPN2 or something.
Exactly, right. So consider a sport versus exercise, but a controlled exercise. But with the chronic conditions, like you mentioned the knee, so a lot of people start thinking, okay, do I need my hip replaced or my knee replaced or my shoulder replaced, which is a little more rare. Is there a treatment in between? Because you go right from, okay, my knee hurts to a knee replacement, or what are the steps that you go through, and what is it that you do in your practice that can help a patient?
That's why I'm there. And it's true, I would say most surgeons are not going to want to operate, in the early stages of arthritis. So, arthritis, you're going to go through stages. And how quickly you go through those stages is affected by a lot of different things. But, at first, you can have mild arthritis, you're going to develop through moderate and then severe arthritis. When you're talking about more mild arthritis, if you're having pain, sometimes the oral anti-inflammatories is all you need, Sometimes modifying activities, switching from higher impact to lower impact activities is what you need. Sometimes physical therapy can be real helpful, especially in the earlier stages. Trying to unload the knees, trying to build the strength around the knees so that we provide cushion, support, and shock absorption, and decrease the progression of the arthritis.
And what other treatments that are a little bit more, maybe slightly invasive or minimally invasive that could help with the...
Once those things fail, then you're usually talking about injections, all right? And there's two types of injections that I use for the knee. The knee is unique. We can do cortisone injections. Cortisone injections I do all over the body. We talked about it for tendonitis. We do it for arthritis as well. but there's also something called hyaluronic acid or visco supplements. Those are only FDA approved for the knee. And the main reason for that is that the studies have all been done on the knee.
Okay.
So there's no theoretical reason why it couldn't be done in another joint, but for now, we only can use them in the knee.
And can it be done on both sides of the knee, both medial and the lateral aspects?
Yeah.
Where it could be...
You know, typically when I do a visco supplement, I'm trying to coat the joint. So honestly, where I put the injection is more just dependent on where I feel like I can get a good
So we're looking at a picture of the knee right now. So if you would describe the joint a little bit, just this is, you would go into this area where the osteoarthritis is being shown, and
right, and so
that
you
would
can
be an
see the
example
injection.
of
And that is one approach. Typically, this approach here that we're looking at, I would use if a patient's in a seated position.
Okay.
So I'll use different approaches depending on the patient. A lot of times, if I don't see a lot of fluid in the knee, and the patient is pretty comfortable with the procedure, I'll do it in a seated position. That's exactly where I'll go, which is on the inner side or the medial side of the knee.
Medial side of the knee. Okay.
Typically, if the patient's a little bit more nervous, or if there's fluid and I'm going to also have to drain fluid out, then I'll lay them down. The problem with that position, when you lay someone down, you can see how when the knee straightens out, it kind of closes off that space. It closes off the
joint, right?
Exactly,
so it's hard to get to the joint.
See.
So actually, in a seated position is a little bit easier. Now I know there's
in that position. In a laying down position, what I'm going to do is I'm going to go from the outside of the knee in a different approach. But as I said, I feel like you get equal coverage from either approach as long as you get it into the knee. The knee has an envelope called the capsule around it, and as long as you get it into the capsule, that medicine will spread around to the whole knee. So there's not, I think some people come in with the mistaken idea, because when you do it for tendinitis, you really aim for the tender spot, and of course not with visco supplements. How often is this procedure
done? How often does the patient have to come in for this procedure?
Right. So basically, there are different brands of visco supplements, and I'm not a proponent of any one brand over the other. There's some brands that have one shot, some brands have 3 shots, and some brands have 5 shots. So it can be anywhere from just once to once a week for 3 weeks to once a week for 5 weeks. And you can do this procedure twice a year for patients. I think it's important to say here that this doesn't fix or cure arthritis. This is just for pain control. It's not a real
regeneration of the cartilage per se.
No, not at all. I think people misunderstand that, and I want to be upfront with someone.
Is the theory to try and create some more cellular activity in there, to try and...
The idea is a lubricant. It's acting as a lubricant to basically, hyaluronic acid is a substance that your cartilage makes to lubricate the joint. It's a natural substance.
Okay. And so you're reintroducing some of what the body may be missing. Okay.
When you have arthritis, you're losing the cartilage that lines your joint. All right. So when you lose that cartilage, not only do you lose
bone on bone, because it's not always bone on bone, but that's what.
Right. But besides losing the cushioning, you're also losing the production of that lubricant. So we're putting that lubricant back in, and there's even controversy about how effective it is, quite honestly. But I've found pretty good success with it, at least for temporary pain relief. I think people have to understand that, it's not like this is going to, like you said, regrow cartilage. It's just going to give you, hopefully 6 months of relief. And prolong the time that you can be active, or prolong the time before you need a knee replacement.
Yeah, and that's good for patients that want an optimistic outlook on, maybe they're a little bit younger, they're not quite ready for the knee replacement.
Well, that's
they want
the
to just kind of
line.
reduce some of the pain.
Yeah.
The arthritis may be,
that's the bottom line.
Mild to moderate. Right.
I always explain to patients that knee replacement has about a 20-year lifespan. We want your life expectancy and the knee's life expectancy to be about one and the same, because it's much harder to replace a replacement. So if they have to go in and replace a knee replacement, then you're in a much more difficult situation.
That's not an easy procedure. We all know people that have had those, and patients that have had those.
So we want to try to get it so one knee replacement lasts your life. So when you ask, well, why would you do something like this? I say if I can get you 3 to 5 years before you need your knee replacement, well, I've done you a service there, and you have to understand that I can't prevent you from getting a knee replacement if you're a young person,
Right.
but I may be able to delay it. And that's, I think, an important goal for you. The other thing to understand is that knee replacements are being constantly updated. I mean, the
materials, yeah, everything's changed.
The surfaces that they use and stuff are better now than they were even 5 years ago.
So the further you can delay
the longer
things.
you delay it, the better a knee you're going to get.
And what do you think about what about the future of medicine, the future of what you do? I see your specialty being critical, like you said, trying to keep people maybe out of the OR.
Right.
What do you see on the horizon in terms of potentially like embryonic
stem cell treatments,
stem cells, regeneration, that's kind of what everyone's talking about.
That's what
everyone's hoping for.
That's
right?
the goal. I don't know how close we are to that. I still think that's kind of far away.
Maybe when we are looking at knee replacements ourselves.
People always come in, well, how come you can't just regrow cartilage?
Yeah.
And the bottom line there is, it's not that you can't go into a petri dish and grow cartilage up. The problem is, cartilage is a complex three-dimensional structure. That's what gives it its a benefit. So just growing cells is not good enough. It's a whole extracellular matrix. It's a whole like crystal, so to speak. Not a crystal, but a whole lattice. And if you don't get that lattice, it would be like just taking a bunch of bricks and just shoving it in a big pile and saying, oh, now there's your house.
There's your house.
You know what I mean? So you can get bricks, but you got to be able to build the bricks and build them onto the existing structure, and that's not so easy. And we haven't found an answer for that. So all the people that say,
osteoarthritis is one of those things that the whole medical community just like truly shrugs their shoulders and says, we don't really know what caused it. There is maybe some genetic factors. There is maybe some autoimmune factors. There maybe is some environmental factors.
Well, there's all of those. There's all of those. But like I said, the bottom line is it's wear and tear. The bottom line is, just like any other, structure or anything, houses
tires
last
on
so
a car,
long, tires on a car,
winding down,
and our joints only last so long. And now some people's joints last longer than others, genetic factors. Some people have had injuries that lead to early arthritis. Some people, like you said, their movement patterns, their body posture kind of predisposes to things over time. But bottom line is 100% of us will get arthritis,
Dr. Shifrin, your specialty is so unique because you can be an expert in so many variables of the body and different conditions. We spoke about acute conditions, chronic conditions. And so I pose a question that's kind of a hot topic as well right now.
Right.
What comes first, heat or ice?
Right. So that's a great question.
And there's been a lot of studies showing don't use ice initially now, when that was the standard for years.
Yeah.
And then some people,
I think that goes back to the same thing I said for the ibuprofen.
Yeah.
The bottom line is inflammation is part of the body's healing response. So people worry that if you shut off inflammation, you're going to delay healing. And I'm not in that camp, quite honestly. I think there's moderation in everything, and I'm a big believer in that. I feel like you've got to weigh the decrease in inflammation versus the swelling and the fact that closes off movement and things like that. So when you ask about that, there's a couple different factors. Acute injuries where there's swelling, I'm a believer in ice. I don't think...
I'm in your camp on that one, yes.
Yeah, I don't think that ice is such a great anti-inflammatory that it totally shuts off inflammation and prevents the healing. So I still think there's enough inflammation going on to prevent the healing. Yeah. And I feel like,
with an ankle, it's still going to swell up. Something's still going to happen there. It's just you're going to just make it not blow up three times the size, which is good.
And when it blows up 3 times the size, that delays what you can do with it. That delays the movement and stuff. And the sooner you're moving it, I say the sooner it gets better. Right. So I definitely believe for acute injuries, especially with swelling, I use ice. And I'm not a believer in this. I hear a lot of people come in, oh, I heard only 24 hours for ice, only 48 hours for ice. My bottom line is if it's still swollen, ice can still benefit it. In terms of the heat, I use heat to loosen things up. So, when you're talking about things like that, if I think it's a muscle problem, I use heat. If I think it's a tendon problem, I use heat. If I think it's a joint problem, or a bone problem, I'm going to use ice. Right. So that's where it comes in.
One thing with patients that we probably see a lot of, herniated discs. A lot of herniated discs out there, and over the years, you know what? When they have pain, then I tell them if it's pain enough that you feel like you need an Advil, an ibuprofen, or something stronger. Right. ice typically will at least calm down the nerve endings. And,
Right.
and patients will
That's
always say,
true.
the ice did help.
Right.
Even though it's a chronic condition, they may have had it 8 weeks, 10 weeks, 12 weeks. When it flares up on them and they ice it down, it seems to calm down. But then I tell them, you know what, once it calms down, try some heat. I actually will tell them to alternate sometimes.
I do that too.
You know,
I believe in what we call a contrast baths kind of system where, you're going to use some ice to decrease the inflammation, to turn off those pain fibers, like you said. That's an important thing. And then you can use the heat to loosen it up so we can get you moving.
Like opening and closing the healing gates. It's kind of like bringing lymphatic and blood flow through the area.
I couldn't agree more. I couldn't agree.
So that's great. So we're not supposed to agree on everything, but that one we do. So.
All right. So every once in a while we'll agree, right?
Well, Dr. Shifrin, really, it was a pleasure having you. It was great conversation, great topics. I think everyone should know about a board primary care sports medicine physician. I think every person that does any kind of athletic, sports, whether it's their children, whether it's themselves, should actually have you in their Rolodex, because it's important to have that type of doctor in your sort of repertoire of professional care. So I really appreciate it.
Thank you for having me.
Thanks for having me. Okay, thanks. Bye-bye. All right, thank you for watching our show, Health IQ. I'm Dr. Alan Siegel. Good night.